Okay, well, we might make a start. Good afternoon, everybody in the room and online, and welcome to the American Heart Association, American Academy of Paediatrics and European Resuscitation Council guideline release event. My name is Jason Ackworth. I'm a paediatric emergency physician from Queensland in Australia, and I have the pleasure of serving as the Vice Chair of the ILCOR Paediatric Life Support Task Force, so I'll be the facilitator for this afternoon. I'll talk briefly about the way we're going to be running this session, but just for those people who are online, we will have an ability for you guys to interact. There will be Slido instructions for you. There's an ability to ask questions. If you click on the question mark in the bottom right-hand corner of your screens, you should be able to ask the question. We have a limit of 200 questions for each of these sessions, so can I please ask, if you're using that facility, use it to ask questions only, not for introducing yourself or other things. And we have one of our ERC young investigators who will be looking at those questions, and we'll be asking those when we have our question breaks. So for this session, I feel very fortunate we have assembled a group of rock stars in paediatric resuscitation. So I'm just going to very briefly introduce them. You'll see on the slides up there, we have Dr. Tia Raymond, who's a board-certified paediatrician and paediatric cardiologist with additional training in cardiac intensive care. Tia has over 130 peer-reviewed publications in the paediatric in-hospital cardiac arrest, cardiac intensive care and quality improvement literature. She is currently the co-chair of the AHA 2025 Paediatric Basic Life Support Guidelines, so that's why she's here. And she works with me on the ILCOR Paediatric Life Support Task Force for ILCOR. Then we have Benny Joyner. Dr. Benny L. Joyner Jr. is the A. Conga Goodyear Professor and Chair of the Department of Paediatrics at Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo in the US. Clinically, he's a paediatric intensivist. He's serving as the American Academy of Paediatrics, AAP co-chair of the 2025 AHA and AAP Paediatric Basic Life Support Guidelines writing groups. That's why Benny's here to join us. Then you'll see we have Kasper. So Kasper Lauritsen is an associate professor of resuscitation science at Aarhus University in Denmark. Please excuse me if my pronunciations are poor. And he's a physician at Randers Regional Hospital in Denmark and adjunct researcher at the Children's Hospital of Philadelphia in the US. He's been part of the writing group for paediatric life support for the ERC and also serves as an ILCOR EIT task force member. And then finally, Nigel Turner. Nigel is a retired paediatric cardiac anesthesiologist and intensivist from Amsterdam here in the Netherlands. He is a member of the ERC Writing Group for Paediatrics in 2025, a previous member of the ERC Writing Groups for Paediatrics and Education for the 2021 guidelines. Nigel has had a leading role in training in paediatric emergency medicine and resuscitation in the Netherlands for over 30 years, and he has told me that he is retiring from many of these activities after this Congress. So thank you very much for coming along, Nigel. So what we are planning to cover during the next 90 minutes, there'll be if you tuned into the previous the guidelines launch, you'll see that the pediatric ALS and pediatric BLS guidelines are quite extensive. So rather than trying to give a summary of each of those, the panel here have picked out their favourites. We have chosen topics that we assumed would either be exciting for people because there are changes in there, or that would facilitate some quite good discussions because of the differences that we have in the ERC and the AHA AAP guidelines. So we've chosen the following topics: recognition and call for help, the sequence of resuscitation, so A, B, C versus CAB, and defibrillator pad position. We plan to run those three questions. We'll have each of our somebody from the ERC and then somebody from the AHA, AAP talking about what their guidelines are, describing those, and then we'll actually delve into what the reasoning behind those guidelines were and why there may be some differences. We'll summarise that then, and there'll be an ability to ask the questions related to those guidelines. After the first three, we'll have a break, ask some questions around those, and then we'll do our final three. the compression ventilation ratios, chest compression technique, particularly focusing on infants, foreign body airway obstruction, and then we'll have another break for questions for those. And then finally, there should be some time at the end. And I've also asked each of our rock stars here to describe where they think the main gaps in the literature are for future research. So what we'll do is we'll move on to our first speaker, and we'll be talking initially about the AHA and AAP. So over to you, Tia.
Great, thank you. So just to briefly summarize, the International Liaison Committee on Resuscitation, or ILCOR, leads the global effort to review and synthesize the latest resuscitation science. The ILCOR committee is made up of experts from councils all over the world, with the American Heart Association representing North America. They use a rigorous evidence evaluation process to create what's called the Consensus on Science with Treatment Recommendations, or the COSTAR. Their focus is sharp. They identify what's truly supported by the evidence, highlight where the gaps may be, and point out where practice needs to evolve. That global science is the foundation for everything that we teach. But the global evidence is actually just the starting point. This is where the AHA and the American Academy of Pediatrics step in. Together, our conference has translated that international evidence into the guidelines that in real American healthcare settings takes place. There are multidisciplinary writing groups, like the one that I had the privilege to serve on with Dr. Joyner. We take ILCOR's COSTAR as the base. We then interpret and apply that to U.S. context. We think about the realities that our providers may face, the EMS calls, the hospital codes, the pediatric emergencies that happen every single day. Every 5 years, those efforts culminate into the guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, which were published today. The goal is very simple: to take the best science and to then turn it into recommendations that are clear, evidence-based, and actionable. And then comes the final step, making sure the guidelines don't just stay in textbooks. They're operationalized into educational programs so that frontline providers are trained to deliver the care that matches the science we discover. That's why programs like the NRP and PALS matter so much. They are built directly on the AHA and the AAP guidelines, updated alongside with them. When you teach these courses, you're not just teaching skills, you're delivering years of international research, refined for American practice and ready for real-world use. So the flow is global science, guidelines, education, and action. This collaborative, multi-step process ensures resuscitation science doesn't just live in journals, it flows into classrooms, into code carts, into delivery rooms, and ultimately into the hands of those people who save lives. Guidance becomes local action, and research becomes rescue. And you, the healthcare providers and instructors who are both here today and online today, are the ones who make this transformation happen. Specifically, the AHA and the AAP evidence guidelines, again, begin with research operations from both of these communities. The first question we ask is there an active ILCOR PICO for whatever question we may be proposing? If there is, an ILCOR scoping review or task force systematic review or evidence update, and the answer to that is yes, then that is incorporated into our guidelines. If the answer is that there is no active ILCOR PICO, then the ECC Science Subcommittee submits a request to ILCOR to review that topic. ILCOR may review it, in which case we follow the same outline on the left. If they choose not to review it, then it's left up to the AHA and the AAP writing groups with assistance from our librarians to develop the science and the evidence.
ERC and how it's different?
Thanks, Tia, I should say, for extensive discussion of the role of ILCOR in this process, and also, most important, the end purpose of it all, which is to improve the quality of life for critically ill children and their families. That allows me to summarize what the ERC did, which was broadly the same. Our process started by looking at the topics to be addressed, and we did that on the basis of outstanding issues from previous guidelines and other issues which had come to our attention as a result of the previous guidelines. We also looked at input from the communities and, of course, topics which ILCOR was addressing in systematic or scoping reviews, which we didn't have on our list. We then agreed within the writing group for pediatrics on what those topics should be. Next step was to look to see if ILCOR had run a review on each topic. If so, we accepted that as the state of science on that issue. If, however, the ILCOR review was quite old, we repeated their search to make sure we had not missed any more recently published evidence. If there was no ILCOR review on a particular topic, we performed our own scoping review, where we looked at random controlled trials, systematic reviews, and previous evidence-based guidelines. If necessary, we also included observational studies and experimental studies which address specific issues within each topic. The evidence was then summarized in a worksheet which was discussed in detail within the entire working group, some iteratively until we reached consensus or near consensus. The golden rule which we applied was that if we could find no evidence for a change in the guidelines, we kept the guideline as it was in 2021. In other words, we did not reopen a review of older evidence on which the previous guidelines were based. We also considered input from a community specialist. Each group had somebody who did not have a medical background in the group. In our case, we were supported by the mother of a daughter who had undergone a cardiac arrest and who was also a lawyer. The whole guideline was then written up in draft form and submitted for public comments at the beginning of this year. And after the input from comments from the public, which weren't very many, we wrote the definitive guideline, which is published today. Thank you.
Thanks for the overview. So we might get straight into the meat of this. So now we're going to go with topic by topic and actually see which of the where the differences are, where the similarities are, and what there is to talk about. Casper, can you just put it forward one, please? So our first topic is going to be around the recognition and call for help. So Casper, ERC.
Thank you very much. So the 2025 ERC guidelines for pediatric basic life support have updated the recommendation on the approach to recognition and call for help. And the updated sequence is that everyone should check for safety, assess consciousness, call for help, check breathing, and then start CPR.
Okay. Thank you. And Benny?
So for the AHA and the AAP guidelines, we really focused on, again, those two recommendations that are listed up there. There's a largely consistent lay rescuers should begin CPR immediately for any infant or child who is unresponsive, not breathing normally, and does not have signs of life. They should not check for a pulse, and we'll get into a little bit of that in a moment. And also in infants and children to know the signs of life, it is reasonable for healthcare professionals to check for a pulse for up to 10 seconds and begin compressions unless a definitive pulse is felt. And so there is a little bit of a distinction between lay rescuers and healthcare professionals even within the recommendations themselves.
Okay, so we're using the same evidence from ILCOR for this topic. Casper, do you want to explain what was behind the ERC's decisions to go with what you went?
Yeah. definitely. Thank you very much. So the ERC recommendation has been updated, and we have tried now for the first time in the ERC to have a shared approach for the assessment of basic life support for both pediatric and adult patients. So, and that has been to, first of all, have hopefully a shared message to the population and also the most simplified approach. And that has been a number of different considerations that we have been taking into place for our recommendations. First of all, we recognize that we need to call for help as soon as possible. Second, we recognize that many lay rescuers have difficulties to assess breathing. So we recommend that once you recognize that a person is unconscious, you should call for help, and then you can start checking for breathing while the phone is going on through the EMS. Yeah, and overall, in terms of assessing breathing versus pulselessness, we emphasize that the ILCOR review did not find that pulse check is a reliable method for diagnosing cardiac arrest, and then we have prioritized to keep our recommendation unchanged for consistency in terms of whether to check for pulse or not.
Okay, thanks, Casper. Benny, there's some subtle differences with your approach. Do you want to talk about the reasoning for that?
Sure. As you stated before, there's a lot of similarities in what we talk about, but there are some subtle differences. So really looking at lay persons and healthcare professionals. And one of the things that we did draw out, as you can see, that's going to be new for the 2025 guidelines, is a simplified infographic for laypersons. Well, we appreciate that the effectiveness of a pulse check for laypersons and healthcare professionals perform similarly poorly, as Casper alluded to. I think one of the things that's a little bit different is that for the lay person, we really wanted to emphasize, just as the ERC did, calling early, like not spending so much time and focusing on trying to assess for a pulse, calling for help early, starting CPR quickly, and really trying to simplify that process for the layperson so that they don't get too bogged down in trying to follow a complicated algorithms. So if you see it, it's really 3 simple steps. It's act fast and get help. It's give compressions and breaths, and then use the AED when available.
Okay, thanks very much. So just showing up our the 2 different guidelines again, we've said that there's a lot of similarities in it, but there's some subtle differences, particularly around the utility of the pulse check or not. We might save our questions for that at the moment. I'm sure that'll be controversial, and we'll just go on to our next topic.
Yeah. So for sequence of resuscitation, the ERC recommendation is unchanged. We recommend to initiate CPR with 5 rescue breaths and then start CPR 15 to 2. And then we have, for the 2025 guidelines, we have added a statement that if ventilation equipment is not really readily available and you are like in a hospital setting, then you may start compressions if unable to do otherwise.
Okay, so the rescue breaths are still there, Casper.
Yes, we recommend starting ABC.
Okay, and Tia.
Yes, so for the AHA and the AAP, our 2025 guidelines are also unchanged from 2020, however, differ from the ERC. Our statement is that it may be reasonable to initiate CPR with compressions, airway breathing, or CAB, over airway breathing compressions, or ABC. And then secondly, for infants and children with a pulse, but absent or inadequate respiratory effort, we do think breaths should be provided and are critical.
Okay, so there was some ILCOR evidence around this. Let's just dig into this a little bit more to see how we've interpreted the same ILCOR evidence with different guidelines.
Yeah, thank you very much. I think here it's actually important to allude to the fact that, as Tia pointed out, this is actually a historical difference that exists between the AHA and the ERC. So not so much whether we necessarily have been interpreted the ILCOR recommendation or the ILCOR statement really differently. But when the ERC has been looking at the evidence provided from the most recent ILCOR review, also just published today, there is no clinical studies to inform this question. We only have simulation-based studies suggesting that ventilations first give longer time to first compression, but then shorter time to first ventilation. We still keep in mind that hypoxia is a frequent cause of pediatric cardiac arrest, and then the ILCOR recommendation is still that you can suggest to use either an ABC or CAB approach, and based on this insufficient evidence, then we have kept our guideline recommendation unchanged to start with 5 rescue breaths.
Okay, so Tia, you guys kept your different path.
Yeah, so for our assessment, that there was one pediatric study that demonstrated only a very small delay, so a little over 5 seconds in the commencement of breaths when CAB is used compared to ABC. Secondly, although supporting evidence is minimal, continuing to recommend the CAB pathway likely results in minimal delays in giving breaths, and it allows for consistent approach to cardiac arrest in both the treatment of adults and children. So the AHA currently recommends CAB for adults also. It is recommended for chest compression only for those lay rescuers in the adult patient. We do not recommend that in children. We advocate for breaths, but for ease of education of all lay providers, I think that the AHA and the AAP feel like the CAB for both infant, child, and adults is easier from an education perspective. And then when CPR is initiated, the CAB sequence, like I said, mirrors the adult sequence. And again, this just allows for educational simplicity when it comes to training. And I think that's probably why we've stuck with it.
Yeah, so I just want to reinforce there that it's clear from both the presentations and both the guideline discussions that people are still want to maintain the importance of the ventilatory component of CPR in paediatric resuscitation, and there were no way saying that trained professionals should be going and doing chest compression only. However, the same evidence is just people. It's not enough for people to change what they're currently doing, and there's some of the educational implementation things that have come into that. Okay, we'll hold off those questions again, and we'll just go on to our final topic for this section. So, Casper, again.
Thank you very much. So for the compression to ventilation ratio, the ERC keeps the recommendation unchanged from 2021. So we suggest to use a compression to ventilation ratio of 15:2 if you are specifically trained in PBLS. And that is at the level of an ERC, Pediatric Basic Life Support course or equivalent. Otherwise, if not, use a ratio of 30:2. And we continue to recommend that that bystanders should be encouraged to do both compressions and ventilations, but if bystanders are not willing or able to perform rescue breath, then it is reasonable to do compression-only CPR.
Okay, so your split is according to the training of the person who's the rescuer. Okay, thanks. Benny?
Yeah, thanks. So for the AHA AAP guidelines, we are taking a slightly different tact. So for our first recommendation, if lay rescuers are unable or unwilling to deliver breaths to an infant or child in cardiac arrest, it is reasonable to provide compressions-only CPR. And then when providing CPR without an advanced airway, just sort of making a note of that, it is reasonable for single rescuers to provide a compression to ventilation ratio of 30:2, and for 2 rescuers to provide a compression ventilation ratio of 15:2 for those pubertal children.
Okay, so both sets of guidelines are really saying to people, use some ventilations if you can, but if you can't, please at least do some form of CPR.
Absolutely.
But your split in your one is more on the number of rescuers that are available. Okay, let's delve into those a little bit deeper. Casper?
Thank you very much. So the reasoning for the ERC recommendation is, first of all, it is based on also limited evidence for this specific question. There are cohort studies suggesting that CPR is associated with better outcomes compared to compression-only CPR, which is why we keep the recommendation that lay rescuers should, whenever willing and able, do both compressions and ventilations. And we also recognize that bystanders are actually frequently willing to provide CPR in children, so both compressions and ventilations, as they are often the primary caregivers. And then we keep the recommendation of 30:2 for untrained laypersons, and that is to reduce the number of switches and to simplify our instructions, and keeping in mind that for all adult basic life support in Europe, they learn to do 30:2. We recommend 15:2 for trained laypersons, and that is to prioritize the ventilations as compared to the 30:2 approach for adult basic life support. And then we recognize that there's no direct evidence really showing any superiority of any specific approach. So, yeah, again, we kept our recommendations unchanged.
So trying to keep it simple and consistent, and in the lack of evidence for change, you've just kept it the same. Benny, how about you guys?
Yeah, I think, thank you, Casper. I think, along those lines, I think trying to keep it simple for training, especially of laypersons, is really important. One of it's just for educational ease, as we're trying to think about how to talk to individuals. If you have, one rescuer, it's 30:2, and you can just move forward, whether it's for children or adults. I think it does come into a little bit of play when you look at the evidence, because one, to your point, Jason, doing something versus doing nothing is vital. So whether it's CAB, ABC, do something, whether it's 30:2, 15:2, we want you to do compressions. The challenge becomes, the amount of switches and how we're able to handle those switches. And I think a little bit of the interpretation of the data from our perspective was, well, you have laypersons who may, not necessarily be as comfortable as trained. And so I think that trying to maintain that, but, really, if you have 2 rescuers, it might be a little bit more easy or effective to do that. And then we just all know that those errors that'll happen when people do switch off. So.
Okay, thank you. So if we just summarise what's going on with the compression to ventilation ratios, we've put those up there again. We see the subtle changes in the 2 different approaches. ERC make their difference according to your training, but the AHA and AAP do have a difference there, focused on whether it's a single or a multiple rescuers. That's our first 3 topics done. So I want to take a little break and open up to the room for questions. Can I ask for people in the room, if you have a question, can you please have a mic, then just say who you are, where you're from, and then please ask your question, and then we'll go to the people online. So questions from in the room. Okay, do we have questions from online? Oh, okay, well, I'll take my question.
Thank you. My name is Daniel Morin. I'm from France. I'm very sorry for my poor English, but I have one question about the first situation when you talk about healthcare professional to take the pulse. In your studies, have you any idea of the level of what kind of healthcare professional do you consider for not to take the pulse in the situation that you have explained?
Yeah, I'm not aware of any specific differentiation between, if you're asking about the healthcare professional as a physician, nurse practitioner, nurse, I don't think that there's a clear delineation that I recall, and I'm looking at my learned colleagues.
Yeah, so in the one study, it was healthcare professionals, and the pulse palpation accuracy was 78% compared to lay rescuer accuracy, which was 47% at 5 seconds, and then 73% at 10 seconds. But I do not recall, and I do not think that they elucidated what type of healthcare professional it was.
And otherwise, there's I think, like, we still rely to a large extent for pulse check on the old evidence that is, I guess, I believe it's around 20, 25 years old, based on paramedics trying to assess pulse on patients undergoing cardiac surgery, so with or without pulse, to detect, and those studies, they looked at, I can't remember, some kind of like a year of experience or less. Yeah.
Thank you.
And just to add, just from our work over the last couple of days here at ILCOR, this is a planned scoping review for the next cycle, and it's going to be a nodal review from the Pediatric Task Force and the Adult Task Force, looking at level of consciousness and assessment of pulse. So there may be something new next cycle round, and the AHA and the AAP may evaluate that evidence differently.
And maybe that's a data point, looking at the type of healthcare professional, whether it's a physician, an EMS provider, a nurse, or whoever.
And I think where we have a look at the evidence, whether it's healthcare professional or not, it hasn't really been evaluated in people with cardiac arrest in the middle of the stress that goes with that. Right. So if we recognise that as healthcare professionals, we're still pretty poor at doing it in the cool, calm light of the day, I think it would be a little bit different. Now, the problem, I'm going to put it to the panel then. My question is, Nigel first.
Sorry, could I just ask the questioner if he's thinking of any particular group of healthcare professionals in asking the question?
Sorry, I don't.
Are you thinking of any particular group of healthcare professionals?
It's in my experience. I have in charge of emergency medical services in Marseille in the fire brigade. So we have technicians. There's firemen. At the other are nurses and physicians. So we decided at least that in all the situations they don't take the pulse, they don't try to find the pulse. They begin in all the situations. Even each level is the same for us, and I think it's better to go faster to make CPR in this situation.
Yep.
And I suspect in real life, for many of us who are health professionals, we probably have a greater chance of seeing somebody who's in a cardiac arrest than the lay population. But none of us would, in real life, use the pulse check as the only sign that we need to start resuscitation. We are looking at the patient, and generally when they look like they're arrested, we will start stuff. The interesting thing for me is we use one of the fears with this is that we use the pulse check at other times within our algorithms for assessing the return of circulation. And if we're de-emphasising the pulse check here, what impact does that have on the rest of our things?
Yeah, I think there's one important point here. That you only suspect a return of circulation on the basis of a conglomeration of signs. It's not that you only look at the pulse. If you think, oh, this child has now got a nice colour, oh, I see that the VF has now changed to a potentially perfusing rhythm, then you've got time to feel the pulse, haven't you? Because you think, yeah, this child is probably okay. Yeah? So the chance that you'll waste time feeling the pulse is not as important as the case at the beginning of the resuscitation, when the child is probably not okay, and then you don't want to spend your time feeling for a pulse. That's how I see it.
Okay, I like that interpretation. Okay, so you're saying that it's actually the chance of us making a mistake is less important later on than it is right at the start with the delays.
I think statistically that's the case. And if you play bridge, you'll understand what I mean.
Okay, I'd like to move on to rescue breaths. Okay, it is a big difference and an area of contention for the groups. Based on that, it seems to me that the bigger decisions are made, and our most recent science is around, based on a mannequin study, which showed a slight difference in things. And people have chosen different ways according to, well, there was a short, if you start with chest compressions, it only results in a short delay in starting your breaths. But if you start with breaths, they're more important, and it's a little bit of a delay in the compressions, which may be a little bit more, and we've chosen down different paths. I can see the logic of people doing it. What I want to ask is, what do you think the impact is on people who train across different areas and move between continents, countries, on having these different approaches?
So I wonder the impact of people and here specifically healthcare professionals. I believe we're talking about moving across continents. I don't believe it's a particular problem of magnitude actually, but myself having been trained a bit in Philadelphia and moving back to Europe, I must admit that I have went to the CAB approach a few times in Europe after just right after coming back. so I believe it does exist, but I think the magnitude of that problem is quite negligible overall.
So I'm going to throw out the challenge to you to rephrase that question a little bit. If some of the drivers that you guys are talking about within your guideline process is to keep it simple and the consistency, yet we have these big differences across things. Why don't we just make it, in the dearth of other evidence to say we should be different, why don't we just make it all the same?
So I would say at least so here we're talking about the regional perspective, and I think to change I think either if you were to change the American approach or we were to change the European approach, that would be quite a significant change on a regional level, right? So I actually think that changing either approach would cause a lot more confusion than keeping the differences.
Right. I was going to say, I think change is hard, and so, some of this is culturally sort of built in. And I think that absent a lot of data or absent, some of the criticisms that we have received on other previous guidelines is what's the data show. So unless there's some compelling evidence to force that change, I think that is, to your point, is it, Casper, is it really worth it to introduce that level of chaos on either? And because then we're going to have to decide which one are we going to go with? Are we going to go with CAB or are we going to go with 5 rescue breaths?
But I mean, so overall, I think, and this is also a part for the discussion at the end of like future evidence. I think this is to me a very interesting question because I think there are in my world there are hypothetically there are several different things talking, pointing in different directions here. So first of all, at least, especially when we're looking towards the scene of adult resuscitation, we see now, I think, more and more evidence suggesting that ventilations are actually a lot more important than what we previously thought for adults. And I think they are not any less important for pediatric patients. So that would, to me, hypothetically again, let me think of, okay, perhaps it is a very good strategy to start out with the 5 rescue breaths as we do in Europe. On the other hand, so Tia and I, we published a paper last year looking at chest compression pause durations and impact on survival outcomes for pediatric cardiac arrest, suggesting that the chest compression pause duration seems to be actually as important for children as for adults. And then based on that data, you could then, on the other hand, question, well, why do we then in Europe start off with a long chest compression pause, providing ventilations? But of course, that was not something that we specifically looked at in our previous publication. And I mean, overall, we just still don't have any clinical data to inform on this.
Well, it sounds like both sides have decided, well, for no compelling reason to change, we won't change. But I'm just going to point out the ERC have made a little bit of a change. It's almost like you've opened the door there and you've recognised and said, well, look, it's okay. If you don't have a ventilation device there to do it, please start with compressions. What are you doing there?
This is a very interesting question, and this is based on I think multiple observations from simulation-based data, where we have seen hospital providers actually not starting CPR because they have been standing in a setting where they didn't have a bag available to start, ventilations, and in those cases, then they have simply waited to start CPR. And I think really what we are trying to say here is that no matter which setting you are in, you should always start.
With something.
Yeah, I think just to add one thing, the way we phrase that in the ERC guidelines is if you are unable to do ventilations, for instance, a bag and mask is not available, and there's a contraindication to mouth-to-mouth ventilation, then start with compressions. So we acknowledge that this is a second best policy to do compression-only CPR, but if there's no other option, we fall back on what we just said. Doing something is better than doing nothing.
Right. Yep.
Yeah.
Okay, any other questions from the group on those topics? I just checked, we don't have questions from online, so we might move on to our next bank of the three topics. And I think we have, the first one's around the infant chest compression techniques. And Nigel, you're going to kick off with that.
Yeah, thanks. The ERC recommends the use of the two-thumb encircling technique for chest compressions in infants in all situations. And this is a very slight change from our 2021 guidelines, which suggested that either the two thumbs or the two-finger technique was acceptable for untrained rescuers guided by dispatchers. So we now specifically also recommend the two-thumb technique for dispatcher-guided resuscitation. We recommend using one hand to give compressions if the rescuer is unable to encircle the chest with the thumbs. And one thing that I noticed comparing the AHA and the ERC guidelines is that the ERC has always suggested or recommended putting the thumbs on top of each other in the middle of the chest, whereas the AHA has always suggested or recommended putting them next to each other. So maybe we can discuss that in the Q&A in a little while.
So from the AHA and AAP perspective, we actually have come to the same conclusions. And this is a major change for our 2025 guidelines that for infants, rescuers should compress the sternum using either the one-hand technique, which is the heel of one hand on the sternum, or to use the two thumbs encircling hands technique. We recommend that if the rescuer cannot physically encircle the chest, it is recommended then to use the heel of one hand technique. And you'll see from the pictures, as Nigel has pointed out, the green gloves have the thumbs on top of each other, and the blue gloves have them next to each other. And I will have to say, it is not something that I have ever noticed until we began planning for this session.
Nor had I.
Yeah. So I don't know, do we both make it up?
Well, this is actually going to be my question for further research.
Yeah.
Okay, well, we'll hold on to that and we'll move on to our next thing. So again, let's talk a little bit about the reasoning behind this. So, Nigel?
Yeah, the reason for the change, I think, at both sides of the big pond was that two thumbs encircling technique gives a much better compression depth, leads to less fatigue, and a more accurate placement of the digits than using two fingers. The ERC actually looked at modifications of the two-thumb technique. We looked at two possible modifications. One was the cross-thumb technique, where the thumbs are crossed, not even on top of each other or next to each other, but crossed. And one in which the thumbs are used to compress the sternum, but the fists are in the air. That's the two-thumb fist technique. There was actually no advantage to using either one of those, although the cross-thumb technique did lead to less subjective fatigue than the two-thumb standard technique. It also seems that the two-thumb technique is quite easy to explain to untrained rescuers. In a simulation study from France, as it turns out, from Bordeaux, They instructed novices to do infant resuscitation using 2 fingers or the 2-thumb encircling technique, as if they were receiving instructions from the dispatcher. And they found that the 2 thumbs technique led to a better quality of CPR. So that's why we changed to recommending 2 thumbs for every situation. There is one experimental study which suggested that using the 2 thumbs might lead to less minute ventilation than 2 fingers. But that was a study in neonatal resuscitation, using, of course, a compression to ventilation ratio of 3:1. So it's a bit doubtful how relevant that is for pediatric resuscitation.
And was that just, they think, related to just the change? It takes a little bit longer to change over
Probably,
from
yeah.
to the breaths. Okay. Thank you, Nigel. To you.
So from the AHA and the AAP perspective, prior recommendations were actually based solely on mannequin studies for optimal compression technique across various pediatric age group. But it's new evidence that was published in 2023 from a registry study of the VIPER registry that has led now to actual outcome-based recommendations. There were 5 systematic reviews or meta-analysis simulation studies that did suggest that the 2-thumb encircling hands technique was superior when it was compared to the 2-finger compression technique, and that was particularly for the depth of compressions and achieving target. There was one multi-center prospective observational registry study that showed the one-hand technique did result in greater compression depth than the 2-thumb encircling technique in infants, with no difference in the rate between the 2 different compression techniques. It was also noted that in this study in 23 from the VIPER registry that the 2-finger technique was rarely used in the study, although it was present, but when it was used, there were actually no compression segments that were compliant with AHA guidelines for depth of compression. And then finally, there was a single center study that showed no difference in chest compression depth in using either the 1-hand or the 2-thumb encircling technique. But they did note a significantly higher compression rate. You can see there 134 to 118. That was statistically significant with the 1-hand technique over the 2-finger encircling hands technique. So I think, you know, the major difference, I guess, Jason, you'll probably go over, but ERC recommends the 2-thumb encircling technique as their recommended one to use. AHA, AAP does not state which is better. We recommend either and only make a statement that if you cannot encircle the chest with your 2 hands, to then absolutely use the 1-hand technique.
If I could just say one thing there, that might have something to do with the way the guidelines are formulated, which maybe I should have made clear at the beginning. The ERC guidelines actually begins with a step-by-step advice of what to do, pretty much like you would have in an instruction manual, whereas the AHA is, if I may say so, a more scientific paper, suggesting options, as you just said. So if you had to suggest one or the other tier, if you had to write an ERC-style paper, what would you say? Would you say do the 2 thumbs in the first instance or do 1 hand in the first instance?
I never use 2 thumbs.
Okay, right, that's
Never.
my answer.
Okay, well, we might pick up that topic a little bit later when we get to our question sections, because that's a bit controversial. Okay, moving on to our next topic. So while we're on the theme of chest compressions, we're moving over to foreign body airway obstruction, focusing on the differences in chest thrust techniques.
Yeah, thanks, Jason. I think there are 3 important points in the new ERC guideline for foreign body airway obstruction. First of all, the ERC now recommends using the 2-thumbed encircling technique not only for chest compressions, but also for chest thrusts in infants in the case of foreign body airway obstruction. Of course, we still recommend starting with back blows as the first intervention in all ages, and abdominal thrusts as the second intervention in older children. Second point, it is if the child becomes unconscious during attempts to remove a foreign body, the ERC recommends starting the CPR using the 5 rescue breaths, as opposed to chest compressions. This is not new, and that is exactly in line with what we've just discussed in terms of the CAB and the ABC technique. And finally, the ERC is unable to make any recommendations on the use of commercially available suction-based devices due to lack of evidence, which we're going to explain more in a little while.
And Benny?
Yeah, from the AHA, AAP perspective, just to sort of piggyback a little bit on what Nigel had said, we're really focusing on where maybe some of the differences or similarities existed. So some of the new recommendations that we had in foreign body airway were sort of reviewed at the very beginning, and so especially as it pertains to the back blows and abdominal thrusts in children that we've incorporated. But for the AHA, AAP, some of the differences that exist is, one, looking at the use of the heel of one hand for chest thrusts in infants, again, using the word thrust as opposed to compression to signify a difference. And then if the child or infant becomes unresponsive, start CPR with chest compressions versus the 5 rescue breaths. And then similarly, though, I mean, the effectiveness and safety of the suction-based airway devices, really we don't feel like the ERC has really been sort of proven or shown, so we didn't make any recommendation about that.
Okay, so we've got some differences there, and the main thing seems to be when you are doing your chest thrust, then what technique you're using for that, and then of course the rescue breaths, but we'll put that aside for the other ones. Let's delve into the decisions around that.
Yeah, it took quite a lot of discussion in the ERC to decide what we were going to do with chest thrusts. We know that using the 2 thumbs leads to a much higher intrathoracic pressure than using 2 fingers. And as we no longer recommend 2 fingers for chest compressions in resuscitation, we thought it would be inconvenient to keep that technique for foreign body airway obstruction. So we recommend using the same technique for both situations, for chest compressions and for chest thrusts. The second difference we've just discussed, that's the difference between the ABC and the CAB approach, which we don't need to discuss anymore, I don't think, at the moment. And thirdly, we know that the standard manual techniques for removing a foreign body can be effective and can be performed immediately with minimal training or with CPR, with dispatcher-guided CPR. They require no additional equipment except perhaps a cell phone. So the question is then whether there's a place for commercially marketed devices at all. The problem is that most of the data on these devices has been supplied by the manufacturers and may therefore contain deliberate or inadvertent bias. And anyway, not all the evidence we could find was positive, as well as potential delay involved in finding the device and in some cases assembling it. These devices have been reported to lead to oral injury. There's also one simulation study comparing one particular suction device with the Heimlich maneuver, and the Heimlich maneuver led to a much higher transthoracic gradient, so is likely to be more effective. So at the end of the day, the ERC did not feel able to make a recommendation on the use of these devices in children, or for that matter, in adults.
Yeah. Benny, heel of the hand. Why?
Yeah. Well, honestly, I think some of it just similar to the 2 thumbs. There was a lot of practical discussion around it, because we felt like the heel of one hand, as Tia alluded to earlier, was more effective in generating that pressure, that intrathoracic pressure, versus 2 fingers, and so we were going with the heel of one hand. Versus the 2 thumbs, in which to us had some issues with supporting of the head and neck, especially in an infant. And so discussing the practicality of doing those types of maneuvers is really important. And then abdominal thrusts, we decided against recommending that for infants just because of some of the data that shows that there is potential to cause abdominal organ injury, especially in infants. And so really wanted to move away from that. And then for all the reasons that you stated, Nigel, there's really such limited data around the use of suction-powered devices that we really, this was equally a very hotly debated topic. I think a number of hours I think we spent on it, and I think ultimately at the end of the day we really felt like we couldn't make a recommendation one way or another.
Okay, thank you. So just again reminding the audience of the 2 guidelines, based on the same evidence, both have now moved away from any reference to a two-finger technique for the chest thrusts in infants, but one side has decided to go with the two-thumb encircling technique as the primary one, and the other one the heel of the hand. And we had the previously noted differences in whether the rescue breaths come first or the ventilation start later. So for our final topic, we're going to move on to a defibrillator pad placement.
Thanks, Jason. Yes, the ERC only recommends using paddles in a situation in which pads are not available. So I probably will only refer to pads during this presentation. We can maybe discuss the situation with paddles during the Q&A at the end. The ERC recommends the AP position, the anterior-posterior position, for infants and small children who can be easily turned to allow placement of the posterior pad. And this is subtly different from our advice in 2021, which simply recommended either the anterior-posterior or the anterior-lateral position for pads in children of all ages. We suggest a size of the child of 25 kilos as a guide to which child can be easily turned and not. And this is chosen because it corresponds to the age of the cutoff age for the use of a pediatric modified AED or a standard AED. In older children, not infants, we still recommend using either the AP or the anterolateral position. Can I have that? Oh, it's there already. Good, thanks. In the AP position, the ERC recommends placing the anterior pad in the mid-chest, immediately left of the sternum, which differs slightly from the AHA, I think, and the posterior pad in the middle of the back between the scapulae, which is arguably the same as the AHA. In the anterolateral position, the ERC recommends that one pad be placed below the right clavicle, the same as the AHA, and the other in the left axilla, as illustrated. This description is pretty vague, as we found little evidence for a more specific placement. In fact, competence providers can use the AL position in smaller children, including infants, provided the pads do not overlap. And this will probably require the use of smaller or pediatric pads to achieve this.
Thank you, Nigel. Tia, the AHA?
So for the AHA and the AAP, our recommendation is that either AP or AL may be reasonable in infants and children, and that the largest size pads possible should be chosen, making sure that they do not overlap and have at least 1 to 2 centimeters of separation. For the anterolateral position, describing it in more detail, it's on the right. The first pad is on the right chest with the top of the pad just below the clavicle. The second pad is on the left chest, centered at the mid-axillary line, with the top of the pad on the lower rib cage in line with the sternal border. The anterior-posterior position, the first pad would be on the center of the anterior chest. The second pad would be on the center of the back. And then there is an alternative anterior-posterior position, which is described as the left side of the anterior chest between the breastbone and the left nipple, and the second pad on the left side of the back next to the spine.
Why do you need an alternative?
It's an excellent question. I think it has to do with manufacturing, the manufacturer recommendations of the pads, because they are different depending upon the defibrillator, the manufacturer, and we don't in the AHA recommendations have any recommendations around manufacturer recommendations. I know ILCOR does.
I asked that question. I wasn't sure whether it was related to an alternate related with subcutaneous devices that may be an avoidance of those.
Not that I'm aware of.
Okay. Thank you. So let's delve in a little bit for why these guidelines have been written this way. So Nigel, the ERC.
Yeah, the ERC recommendations are based on evidence which suggests that the AP position is at least non-inferior to the AL position in adults and pediatric studies. For instance, observational studies in adult out-of-hospital cardiac arrest found better ROSC with the AP position, but no difference in neurological outcome or survival. And a similar study found no difference in defibrillation success between the two positions. This, however, was a retrospective study, and the pad position was not standardized. And an older pediatric study from 2011 suggested a tendency to a higher ROSC rate with the AP position in children. So the use of the AP position may improve ROSC, but has not been shown to improve survival or neurological outcome in children, and there is in any case very little pediatric evidence. It's certainly true that the AP position allows the use of a larger pad, which lowers the impedance and allows more energy delivery. But the question of how relevant this is to pediatrics is still unanswered, as we're using relatively larger doses of energy in small children than we do in adults. The AP position also allows the use of feedback devices for chest compression depth, which is an advantage. On the other hand, turning a larger child can be difficult for a single rescuer, and clothes tend to open at the front, and this can lead to difficulty in finding the back and inaccurate placement of the posterior pad. But how important that is unknown. Our description of the lateral pad position is also pretty general, as we could find no convincing evidence for an advantage of a specific position. Finally, the ERC has kept things simple, and we only have one position instead of two alternatives. But being sensible Europeans that we are, our alternative is our position is about halfway through between your two alternatives.
So you're saying you compromised?
No, we didn't actually look at the AHA when we made our decision. Yeah?
Okay, so it sounds like a lot of the discussions at the ERC level were very much practical decisions based on how you'd actually be able to practically place a pad in a resuscitation rather than on some of the other science.
I think that's absolutely right, and that corresponds to what I just said about the difference in the style between the two guideline documents. Our guideline document is much more an instruction manual, first half of it anyway, and after that that's discussed in the scientific aspects, and the AHA is a more scientific approach.
And just last but not least, in absence of evidence, I mean, as we have no evidence, then it's really the practical considerations that come into play.
Tia, what went on in the AHA and AAP discussions?
So one of the discussions was the size of the pads, and both ERC and AHA have chosen the largest size pads possible, but also continuing to recommend that they not overlap. We specifically have a recommendation that they need to be separated by at least 1 to 2 centimeters. And studies comparing shocks delivered to children with pediatric to adult paddles showed that the transthoracic impedance was slightly higher with the pediatric paddles due to smaller size. Secondly, there was one pediatric study that showed no difference in ROSC with either the AP or the AL, so again, lack of evidence. And then one adult study showed higher adjusted odds of ROSC with the AP, while another study showed no significant difference. The illustrations on the bottom are the 3 different recommended pad positions. I will also note I am now recognizing for the first time a difference between the anterolateral position of the left chest pad. We have ours turned sideways, and ERC has theirs in the upright position.
Okay, I'll get onto a question about that shortly. Let's just so if we think about our differences there, we've now identified that there is some slight differences in where the pads are positioned, some alternative arrangements for the antero-posterior position, but generally a preference in both for an AP positioning if you can in the kids. Okay. We've now had our other 3 guidelines. I'm just going to open it up to the room for any questions that people may have from our audience here. While people are thinking, I'm going to go back to our initial thing around the infant chest compressions and ask both groups had decided that the thumb encircling technique was the preferred, and with the ability to use a heel of one hand technique. But both groups also said you use the alternative potentially if you feel that you can't get your hands around to encircle. Aren't you really meaning if you're not effective in doing it that way? Why didn't you say that?
No, I think that depends on the size of the child and the size of the rescuer. We have several smaller people in the Netherlands. You wouldn't believe it, but there are some small people here with small hands who can still play the guitar beautifully. And they have difficulty in encircling the chest. So in that case, we say, okay, then you do one hand as quickly as possible.
And if you can't get your fingers all the way around to the back, are you less effective with your thumbs?
Yeah, that's the big question. The simulation study looking at the two-thumb fist technique, which is basically two thumbs without encirclement, did lead to a lower quality of CPR than the encircling technique. Now, what that's got to do with the fact that your thumbs, you have to encircle the chest completely or only partially to make the effect, I don't know.
Tia?
I was just going to say, I mean, just physically trying, my hands are average size, and even if they can fit around the chest, I mean, I don't do a lot of things with my thumb, and so generating pressure with your thumb compared to the heel of your hand, it would seem to me to be significantly more difficult to try to do that with your thumb, and I think you tire your thumb sooner than you would the heel of one hand. Yeah. I don't know if I could do two thumbs encircling for 2 minutes.
I think just the biomechanics of it, right? When you're using the heel of one hand, as you think about how we teach and how we're taught to do it, it's outstanding. You're you're moving from the hips and not moving from your arms versus, having these small muscles here. And to your point about the biomechanics of it, if you are encircling, the theory is that you're squeezing, right? And if you can't encircle, you're really not squeezing. And so I think, yes, right now as we've had it, it's an alternative, but to me, there is a biomechanical advantage of doing one heel.
Casper?
So I think one of the interesting questions to me in terms of having one hand versus two thumbs, I really much agree actually on your point that of course biomechanically there's probably an advantage of using one hand, but on the other hand, the disadvantage of doing that is your area of compression will easily be pretty large with one hand, and how would that really affect the hemodynamics of the basically the cardiac output of your chest compressions? I think that is something that is a bit uncertain, but at least that is a potential concern. I think that to me, in terms of leading me to prefer a bit using the two thumbs, but again, in absence of better data.
I don't think there is data on this, but it is our unwritten concern that with one hand, we may have less control of how deep we are actually pushing, and concerns in the infant about pushing too hard?
Possibly, yeah. The other aspect of this is the transition from birth to beginning of infancy. And in the neonatal recovery, in the neonatal care, they'll all be doing with two fingers and not with one hand. So all these people in the whole of Europe are using two thumbs and have been doing so at least since the last guidelines, certainly the guidelines before then. And you don't hear stories about fatigue. Although I don't know any scientific evidence on that, I suspect that fatigue is less of a problem than you think.
And so rolling on to the next topic, which was around the chest thrusts, we had a big difference there in that one group was choosing the two-thumb encircling technique and the other chose primarily the one hand. I wonder, with a team who are doing the two-thumb encircling technique, aren't you worried about the head as well if both of your hands are tied up?
Yeah, I was very skeptical about this when I first had it during the discussions in our group, and I think you were too, in fact. My worry was they're going to drop the child if they do this. And one of my other colleagues, who I won't mention, said, yeah, but they're going to drop the child anyway, which I didn't think was particularly helpful for the discussion. And I was only convinced by a number of people who actually tried it out. It does require a different choreography of the treatment of choking, because you need to use two hands, and while you're using two hands to do the chest thrust, you've got the child pretty securely if the child's in your lap. But then when you pick the child up, you've got to move one of the hands back to the head. So that does require an extra intervention. I agree entirely.
So this was indeed also one of the long discussions. And by the way, I'm also very pleased to hear that you had really long discussions about those devices, whether to use that or not. It was also pretty lengthy discussions in the ERC, I would say. Also for really which technique. Again, we are just here in absence of evidence. I think a very strong argument, and the most important argument, is really just to say that, well, we recommend using two thumbs for chest compression, so we keep the simplicity in doing this here. We did really consider, okay, well, would it be too difficult? And I think again that is also something we would actually need to find out more. Personally, I actually had the advantage of having a baby at home while writing these guidelines. So I actually tried to to see if turning around and how would that actually go, and I actually think when we were discussing this, I actually kind of landed on the thing that for the smaller infants where it's really important to keep head support, I could actually easily keep him between my legs, switch him around, and potentially use two thumbs without really pressing him.
So we expect to see some photos within the ERC guidelines of your baby, Casper. Yeah.
Although not.
Now, Benny, did those practicalities factor in your discussions?
Well, I was going to say, I think that both groups probably had a series of, I can only imagine the series of Zoom meetings that were held with a number of people standing there either doing two thumbs or one heel of one hand. Because we certainly were discussing that even as we were talking about the material, the educational materials, like how would we try to teach this. But I do think that there are practicalities that factored into this. One, some of it was the force generation that we talked about, that you're trying to expel an object, and so you want the greatest amount of force, and so using the heel of one hand would achieve, we thought, a higher, and I think the evidence shows, a higher level of force to expel, the object. And the second thing was just very straightforwardly the mechanics of flipping. I think that culturally we've been doing it, with at least two fingers, so everyone's got a sense, and even as we think about it, as we demonstrate it, it's sort of comes second nature to us to hold that your non-dominant hand out. And so I think we thought, okay, doing that with the heel of one hand seemed to make sense.
Okay. Thank you. If there's no other questions, I have
discussion.
I have one final one onto the defibrillation pad placements. We've demonstrated that there are a number of variations in your recommendations for it. I imagine that the people who produce the defibrillator pads, with showing the graphics on the back of them to say where they put it, would love to have it so that across the whole world there was one guideline with showing the positions, and we've created at least 3 or 4 different variations on this. How do we overcome that?
Well, we can go part of the way, as we already have done in Europe, by suggesting that the AP position can be used in all ages. But then so can the AL position, so that doesn't help very much. What we have done in the European guidelines, I didn't mention that, is we recommend the use of one standard pad size for patients of all ages, so for children and for adults, which would then immediately imply or suggest or force the use of the AP position in small children. Otherwise, they won't fit. So that's not an answer to your question, but it is a step in the right direction.
So, allow me to be an angry old man here. No, but so first of all, I would actually say I actually think now that the guidelines are more aligned than ever before, because what I have lacked in previous AHA guidelines is actually proper pictures of where to place the pads in the AL position for both peds and adults. And I think now we are very closely aligned to that. So and I actually think that, so we are actually moving in the right direction for this. I would think. And then the reason why I said I was going to be a grumpy old man now is that looking at the, pictograms of pad placement across different manufacturers around the world for both defibrillators and AEDs, they are simply incorrect. We have multiple studies on that the pictograms provided by the manufacturers are incorrect, both for the AHA and the ERC guidelines. So I would, they have, so far they have ignored us anyway.
Okay, so there's an advocacy role at both our local councils and at an international level to get that corrected. Tia?
Another thing, just to think about in my everyday practice in the pediatric cardiac ICU, we only use the AP position, and that is because of the quality CPR metrics that we get with the pad on the front and the pad on the back, and making sure that you have the resistance and the mattress and all of that factored in so that you can get accurate chest compression, rate, depth. So
it seems like we are evolving towards a commonality with this, but there's still some little nuances in there. Yeah, we'll revisit this in 5 years' time. Casper?
So I actually just have one question, and that was also for the previous presentation in the other room, that the placement of the lateral pad, like having it vertically versus horizontal, and you actually have a specific recommendation on that. That is, like, we have pictures of that, but we haven't mentioned any direction of the pads. And my personal take on that, and at least when I teach, I always say it doesn't matter, because the current goes through the very center of the pad. So which direction you place it, it would give the exact, same current through. So I'm actually a little bit curious, like, why do you have a specific recommendation on the, like, which way to direct the pad?
Same question. Why do you have it to direct it the other way? I mean, I don't know if I actually don't know what the adult picture looks like. I haven't seen that yet. I'd be interested to see if they have it the same way. I suspect they do.
We didn't actually make a specific recommendation to put the lateral pad in the, say the vertical position.
Right.
It's just traditionally the first illustrations we made were with the pad in that orientation, so we've done it. But one question is, your recommendation specifically says the bottom of the pad should be along the rib cage. Now, if you're using larger pads with very small children, you won't be able to put the pad with the bottom on the rib cage because it'll just bend back around the arm, unless you're using the lateral position. So I now understand why you make that recommendation, because of course the lateral diameter is smaller than the horizontal diameter.
I would suggest to both groups that it's much more likely that people will have a look at your diagrams than they will actually reading your text.
Yes.
Probably true, yeah.
Okay. Well, what we will do now is we have a little bit of time, and I just wanted to open it up. I had asked each of our resuscitation experts here to think about gaps in paediatric resuscitation research. And we've already identified the lack of some of the specific evidence around these quite controversial topics that we have. And so we'd clearly like to have some more evidence in this area. And I'm going to ask each of them, if you were to find a bottle that had a genie in it, and you uncorked it, and the genie said you can have two wishes. One was for a randomised controlled trial in the area of paediatric resuscitation, and the other one was for a large cohort or registry study that was done to examine a particular topic. What would be your two wishes? I might start with Tia.
Well, if I'm the genie with the bottle, I have to speak to what I do, and it's advanced cardiac life support in the cardiac pediatric population. And so for a number of years, I have felt that interposed abdominal compression, CPR, particularly for our shunted single ventricle patients, provides more adequate diastolic blood pressure than standard compression CPR. So I would advocate for a randomized control trial in children looking at standard CPR versus IAC CPR.
And in non-cardiac kids, just the whole
In
population.
cardiac and
non-
or non-cardiac,
Okay.
yeah.
Thank you.
I think I would go back to some of the foreign body airway stuff that we talked about. I think that because we spent so much time, talking about foreign body airway obstruction, I would really, and then really about the use of devices. There are people that feel very strongly about them. There are, people that feel, strongly one way or another. And it would be nice to figure out a way, either through some sort of database registry study, because the data that we have out there is on so few individuals, and I think that really skews the ability for us to sort of make an evaluation of it. So I'd like to look at devices in some sort of standardized way.
Okay. Controversial but achievable. Yep. Nigel?
Yeah, I've already mentioned what I would like to look at. That is the position of the thumbs in the two-thumb encircling technique, whether putting the thumbs on top of each other has an advantage over putting them next to each other. Of course, I'm looking there more at simulation trials, I think, than a real RCT. But I would add to that then, as a result of the discussion we've just had, whether it makes a difference the way you put the pad in the lateral position, whether it should be horizontal or vertical. And we're only talking about the RCT trial now, aren't we? Not the registry-based study.
Whichever you like. So this is a part of your legacy, is to basically establish the Turner position.
The Turner position, yeah.
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 Okay. You do get to choose and have another wish.
Another wish. The other wish would then be to look at the pad position generally, particularly in older children and adolescents, whether it actually does make a difference to outcome using AP or AL.
Thank you. Casper?
I think it's really tough that you say only two, because I mean there are so many questions to answer here, and one thing I also have difficulties with is why use cohort studies. I mean, we need to recognize that, like, as you say, like for foreign body airway obstruction, like use of devices, this is just like impossible to do like an individually randomized trial on that. But I think for a lot of what we talk about, like, large collaborations like in the PD rescue or similar settings with like a cluster randomized design, I actually think like cluster randomized designs are feasible and would at least provide better data. So I would actually that would just be like an overall consideration. I think we should always consider the opportunity of cluster randomized trials for a lot of what we're talking about for pediatric life support. But to go more specifically, I think first of all that main question, should we start with ABC versus CAB? I think for like a cluster randomized trial, that would be quite ideal. If we're looking into something I think very achievable and like extremely simple, I would like to start on this tomorrow, and I would like to ask either Tia or Benny, would you join me? So that is basically just this very simple, discrepancy we have between the ERC and the AHA guideline, which is a trade-off when you have a single trained provider, let's say a nurse in like a Department of Pediatric ward, doing CPR. Should you use 15:2 or 30:2? I actually think that's just like a small difference between our guidelines, based on where you say, well, there's a trade-off here because the pauses, they'll simply be too long if you do 15:2. So 30:2 is better, and yeah, we say the other thing around, and I think like that is something that it's a very simple, just simulation-based randomized study that I think we could do together, and I actually really think that we should do it across both Europe and the US to actually compare across settings where we currently have different recommendations.
Okay, thank you. I don't know how it works in your country, but I'd suggest rather than starting tomorrow, maybe consider consulting your health research ethics board.
So actually, the nice thing is in Denmark, for doing simulation-based research, there's no IRB approval. Yeah.
Wonderful. Okay, I'm just going to ask, we're just about out of time. Are there any other questions about any of the things that have gone on today that you want to ask the panel while we have them here, or any other suggestions that you guys have or online for future research directions we should be taking? Any final? One question?
Someone wants to know if using the two-thumb encircling technique will affect ventilation negatively compared to two-finger technique.
Compared to the two-finger. So I suppose it's that question. I'll just raise the question again. The question from online is, do you think that the two-thumb encircling technique will impact negatively on ventilations compared to the two-finger technique? I think there's a little bit of discussion around that as well with the changeover.
I think we did mention that briefly. There are simulation studies comparing the two, and look, because people, when we introduced the two-thumb technique, people were worried that that was quite complicated to get your hands off the chest and put them on the airway. So there'll be more delay between the transfer from compressions to ventilations. But simulation studies suggest that that is not the case. So if that might be an answer to the question. On the other hand, the question might be about asynchronous ventilation and continuous compression. That is, with the use of an advanced airway, if you're doing then compressions and ventilating at the same time, continuous compressions, does it then make a difference whether you're using two thumbs or two fingers? And I don't know.
Okay, and thank you for that question online. Okay, any final comments from any of the panel members? Okay, well, we'll close down the session there. Thank you very much, everyone, for your attendance and your engagement. Thank each of the panel members for their ongoing work in resuscitation. We're going to close the session now, and I'll invite people both here and online to join back in on the other discussion, which will be the summary in our plenary session, which will be starting very soon. Thank you.